Wait for the magic words. There we go. Excellent. Good afternoon, everybody. So my name's Laura Bonnet, and I'm a lecturer in medical statistics at the University of Liverpool. And I'm really interested in the development and validation of clinical prediction models, primarily for chronic conditions like epilepsy and asthma. I have a general interest in prediction modelling in general. And as you'll see from my title, I'm going to present a skeptic's viewpoint. Now, most of this is my own personal opinion, but there is some evidence to back up what I'm going to say as well. So blank screen, it's okay, don't panic. What I wanted to say here is that I think we're all agreed that clinical prediction models are amazing things. They enable us to help make treatment decisions. They can inform patient counselling. They can be used to stratify patients within clinical trials, and generally are amazing things. And they can be built in a variety of ways, from logistic regression, survival analysis, through to structural neural networks and all sorts of other methodologies. But there are problems with the way we develop prediction models, and some of these are perhaps more apparent in AI approaches than in alternative approaches. And so today I'd like to raise my concerns that I'm aware of, so I can either sort of open people's eyes a bit to some of the problems, or perhaps the audience convince me that I'm all wrong and that AI for prediction model is definitely the way forward. I'm up for either option here. So I thought the best way to do this would be to kind of talk people through the way we would build a prediction model. So the first thing we would advocate is doing a literature search, because people build models just for the sake of building prediction models. And what we want people to do is to build a prediction model if there's a clinical need. So we should check the literature. Are there any prediction models for our clinical area? If so, are they of low risk of bias? Are they high methodological quality? And do they answer the clinical question we have? Only at that stage, assuming that you can't answer yes to those questions, would we advocate actually going about building a model. So let's assume that we've checked the literature and there's nothing relevant or nothing of decent quality to answer our clinical question. The next thing we want to do is to build our model. So we need to think about what variables to include in our model. Again, this is where our literature search is helpful, because we can consider our pool of candidate predictors. So in my world, that means our list of potential clinical variables based on the literature. And we'd also talk to our expert clinicians and our participant and public involvement groups to kind of come up with the best list that we think is going to be helpful. We need to think about the sample size. Just because some methodology enables to fit every predictor in the whole wide world, should we do that? Even if we've got 3 million patients in our data set, it's still useful to do a sample size calculation. And times have changed from when I first started modelling. We used to use the 10 events per variable sample size, but we can do better than that now. Richard Riley's group have come up with a series of papers that calculate sample size for various different situations. And this paper that you can see on the screen, the BMJ one, is an overview of those methods. So I suggest this is the kind of first go-to paper when it comes to sample size calculations. So we've got our variables. We know that our data set's big enough to deal with all these variables. Then we build our model. What if we've got missing data? Well, we'd normally advocate the use of multiple imputation to fill in the gaps. We need to think about any continuous variables such as age, weight, and height. What do they look like? Do we put them in just as they are? Or maybe they look non-linear, so perhaps they've got a curve to them. So we need to think about the shape that we model them as. And we also need to think about fitting the best model that makes most clinical sense. Just because you can fit all your variables into your model doesn't mean that we should. A clinician working in a hospital doesn't necessarily want to type in 50 bits of patient information to get an answer out, when a model could do just as well with 5 pieces of information. So backward selection is the preferred methodology for logistic regression and survival analysis, but I'm aware that there are alternatives for AI approaches to prediction modeling. So my first kind of warning caution sign is here. Doesn't matter whether you're using logistic regression or neural networks, we need to think about all these different things, what the literature shows us, what the variables are, our sample size, and how we go about the modeling. And it's not just me that thinks this, which is a relief. There was a systematic review recently of risk of bias in studies you developed using supervised machine learning. And the conclusion was that most studies on machine learning based prediction models show poor methodological quality and are at high risk of bias. But I should just state here, it's not just machine learning techniques that are the problem. An example of another systematic review, this one for COVID models, found equally poor models built using logistic regression and survival analysis. So the problems are consistent throughout prediction modeling. So assuming we've built our brand new model, we need to test its performance because it's going to be perfect or really good for the data we've used to build it. But if we had a slightly different data set, it might be different. So we need to test model stability by seeing if we used a slightly different version of our data, whether we'd end up with the same variables included. And we need to evaluate model optimism. And we can do that using what's called bootstrap resampling. So say my data set is 1,000 patients big, then I'm going to take repeated samples of size 1,000 from that data set with replacement to end up with 20, 30 or so on different data sets. I do everything all over again, including the backward selection, the multiple imputation and so on and so forth. And I assess the model's discrimination and the model's calibration. So discrimination is looking at whether people who are predicted to have the event go on to have the event, and calibration is assessing whether the predicted probabilities match with the observed probabilities of the event. We assess discrimination usually via Harrell's C statistic, and calibration can be assessed in a number of ways, including the calibration plot, the calibration slope, and what we call calibration in the large. I'm not going to go into the specifics, but I can talk about that later if people wish. And once we've evaluated the performance in the original model, and after doing all this bootstrap resampling, we get an estimate of the model's optimism, which we can use to adjust our model. So we've built our model, we're aware that it's going to be better than it perhaps would be, so we've adjusted our model for this optimism. Again, another warning point. We need to always present discrimination and calibration methods. It doesn't matter how you've built your model, we must present both things, discrimination and calibration. Normally you just see a ROC curve or a Harrell's C statistic, and that only tells us half the story. So it's really important that both discrimination and calibration are presented. Next, we go on to test the model's validation in independent data, what I'm going to call external validation. We still want to assess the discrimination, and we still want to assess the calibration, but this is of the model in a new data set. What we're not doing here is refitting a model. We're not saying our model's got 3 variables in it. What are the regression coefficients if I fit those 3 variables to a new data set? And if necessary, we might need to recalibrate our model if there's systematic differences in the underlying risk profile of the data set, for example. But to expand on this point a little bit further, because this is my main concern with some of these methods of AI, and in the previous talk we heard about transparency, and this is for me where it gets a bit tricky. So this is an example of what I mean by external validation for a logistic regression model. Not a pretty one, but a logistic regression model. We have our intercept term, we have our regression coefficients for a number of different clinical predictors. We have a new data set. So for each individual, we have data that we can put into our model. So the first step of doing our external validation would be to get our linear predictor and then our predicted probability of the event for this new individual. And from there, we can calibrate and we can estimate our discrimination and calibration measures. What we often don't see is any evidence of this within some approaches to prediction modeling. So you often see the data, the model's been developed and then it's been tested on independent data, but what's unclear is to whether the new data has been tested in what I call external validation, or indeed whether a model was refit to the new data and the 2 models were compared. So after we've done our external validation, we have a step involving model presentation. There are a number of different ways to present a model for a clinical audience. It might be a point score system, a graphical score chart, a nomogram, or a website. And if you're interested in any of these, a bit of self-promotion here, I've put a link to our BMJ paper on how to present prediction models. And of course, you're likely to want to publish your prediction model in a journal article. And so therefore, we would advocate use of what's called the tripod reporting guidelines. Now, these currently aren't mandated by journals, but we are trying to work to ensure that they are in future. Many people don't think about presenting a prediction model for a clinical audience, and many people don't use the tripod reporting guidelines. If you're unaware of them, I highly recommend the two papers here. The one at the top is the shorter tripod statement, which is a guidance paper. And then the second one is the longer explanation and elaboration paper. And that's great for helping you to answer each of the different questions on the tripod guidelines. And there's more available on the website that you can see there. So what is tripod? Well, a bit like the consort guidelines and so on and so forth, it's a list of items covering a variety of topics. And the one I want to draw your attention to is the model specification 1. 15A specifically states that you should present the full prediction model to allow predictions for individuals. And they go on to clarify this means all regression coefficients and model intercept or baseline survival at a given time point. And then 15B is explain how to use the prediction model. And for me, this is where we're really lacking within the AI approach to developing prediction models. We don't get to see a full prediction model. We don't find out how to use the prediction model. It's a bit untransparent, if that's the right word. Put the data in, hey presto, here's the prediction. Now, of course, this is a tripod reporting guideline, which is clearly aimed at logistic regression, survival analysis, and so on and so forth. However, Gary Collins and team are in the process of developing a tripod AI reporting guideline for diagnostic and prognostic prediction models based on artificial intelligence. So this is nearly at completion stage, and that will be really interesting to see what items that includes. I'm fairly sure it's going to have information about explain how to use the model and so on and so forth. And then the final step along the journey is a clinical utility assessment. So this might be a randomized control trial or similar. And here we're not interested in building the model or testing the model's validity. We're thinking about, does it make a difference? Does it improve patients' quality of life? Does it improve clinician well-being in terms of their confidence in prescribing or making certain decisions? And does it improve use of hospital resources? And this step's rarely done, no matter the approach to the prediction modeling. So, in a slightly whirlwind tour of prediction modeling, I've kind of gone through all the different stages that one should consider when developing and validating a prediction model. And I've raised concerns at each stage of the process. But for me, the biggest one is the external validity of a prediction model developed using AI. There's a lack of transparency in some approaches. There's a lack of reporting in some approaches, and it's not always clear how somebody would use the prediction model in a particular clinical setting. So we need to improve in this area in particular. So what are my suggestions? Okay, so this is the one that I'm really nervous about, but I'm going for it anyway. It's not my paper, it's all right. So in June 2019, a team did a systematic review, and they showed that no performance benefit of machine learning over logistic regression for clinical prediction models. So perhaps I can sit here and say, we don't need machine learning approaches. Perhaps we can just use logistic regression. I realize this might be an oversimplification though. So perhaps what I am going to advocate instead is that we need to ensure that we're reporting everything. So I would highly advocate use of the tripod AI reporting guidelines as they're available to ensure that all steps of the modeling process are clearly described, enabling other people to come along and validate the models and also to use the models for the relevant clinical scenario. So that just leaves me to say that I really believe that clinical prediction models are awesome, but I am aware that there are problems both with traditional approaches and more novel approaches, and we need to be guided to do much better via reporting guidelines and via meetings like this where we can raise awareness of the problems that we are aware of. So thank you very much, everybody. I look forward to answering your questions.
Yeah, thank you very much, Laura. Yeah, on a personal note, I kind of agree largely that, that there's no problem with the underlying technologies. It's more about the development and the presentation more than anything else, and how that can be improved. Yeah, both in AI and in traditional models as well. So there's a few questions to go through. If you can see them, but feel free to go ahead.
Oh, hang on, let me just, I was doing all right with the technology. Okay. Okay, so the first question I think is about calibration. So I've been asked, could I explain a bit more about calibration phase? So calibration isn't a phase, it's a concept that's rarely reported, to be honest. And calibration is looking at whether the predicted probability of the event according to the model matches the probability of the event according to real life. So you'd normally see it as a plot, and I'm going to do my hand signals here, where you've got predicted probabilities and survival probabilities. And then what we want to see is all the points, so the probabilities for each individual in your data set lying along the line of agreement. And that would show that your model was perfectly calibrated. The model will be really well calibrated for the data it was built upon, because that's the whole point. But as soon as you move it to a bootstrap data set, or indeed to an independent data set, we often find that calibration becomes a bit off. A model underestimates or overestimates survival, or whatever your outcome is. Hopefully that's helpful. Then Irene says, do I think that there should be a requirement for models found in the literature search to be tested before starting on building a model? I would love it to be. I'd love it to be a requirement that we build and we do a literature search to identify whether we actually have to build our own model first. But we've got a long way to go before that, I believe, because we currently can't quite convince journal editors to ensure that the tripod reporting guidelines are submitted along with when we submit work to a journal. So I think to enforce a literature review on top of that is going to take some other work, but we will do our best. And then Deborah Stocken says that the transparency of the algorithm is really important. So excellent. Somebody keen on my side, that's great. And Richard Riley's provided a link in the chat that hopefully everybody can see about the importance of calibration. Thanks, Richard. And somebody's asked me directly if the papers that I've talked about will be available after the talk. So I'm going to refer to Sam here and ask whether the slides will be made available afterwards.
I'm happy for them to be if you are, yeah, and certainly the recordings will be.
Brilliant, thank you. And then one other question, Dewey's asked me, will these guidelines support inclusion of molecular data such as genes? I honestly don't know. I've been involved in the work towards the development of Predict AI, but I can't remember off the top of my head whether it supports molecular data. I suspect it will do, but we'll have to wait and see when the paper's published.
Perfect, thank you very much. So in that case, that's well, that's bang on time. So that doesn't happen very often, does it?